Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
I'm excited to bring you today's guest, who is Dr. Paolo Ronconi. Dr. Ronconi is an orthopedic surgeon specializing in foot and ankle surgery. I've had the great fortune to have become a colleague and, more importantly, a friend with Dr. Ronconi since the mid-1990s, when he talked and taught me the osteotomy that we're going to share with you today. I have been using this osteotomy since the mid-1990s, when he instructed me and showed me how to perform it. It is by far a superior way to address most of the cases of hallux, limitus, and rigidus. Of course, it will not address stage 4 arthritic first metatarsal phalangeal joints. But if you have patients that are having lesser metatarsalgia, you always need to look next door to the first metatarsal phalangeal joint and see what's going on there. And of course, you always need to address if there's any equinus present as well. But I hope you take the time to look at this conversation on the video, as I think it will give you another weapon in your armamentarium against a very common condition, hallux, limitus, rigidus. Thank you, and without further introduction, Dr. Paolo Ronconi. Hello, everyone. I am here with Dr. Paolo Ronconi, who is a friend of mine, and I've actually known Dr. Ronconi since probably the early 90s, I believe. I know it was 1996 when I first came to see you perform the osteotomy that we're going to talk about today. So I guess it's evening there in Rome, so good evening, and thank you for taking time to join the show today. So, Dr. Ronconi, can you tell a little bit about when we first started talking about this osteotomy and how I was really, when I saw what you were doing, we were putting a lot of implants in for replacement. And when I came to visit you, you were able to share with us how you were able to avoid a lot of implants and had very long-lasting and good results with your decompression osteotomy.
I want to introduce myself. I am Dr. Paolo Ronconi, orthopedic of Rome, past president of the CISPEC, Italian Society in Foot Surgery. I have written several texts in orthopedics, and in particular in biomechanicals, one of which in English, written in a collaboration with my friend Stephen Barrett. On YouTube, you can view several films, movie made in the years of biomechanical and displayed in 3D studio, both in Italian and in English, and that are at your disposal. My presentation will begin with the basic concept on biomechanics, and then I will talk about the osteotomy technique and its applications, including in hallux varus. I have here near me Arianna, my nipote. She speaks English better than me, and she can help us a better linguistic exchange if there are any questions.
Excellent.
Excellent. Allora, distal osteotomy. There are many causes that can determine an hallux rigidus. We talked about in the introductory part on biomechanics, and you don't have to. Normally, we use the Köglen classification, you know that. Stage 1, we find a functional hallux limitus premature, no joint degeneration. In the stage 2, instead, we find a pathological process visible on X-ray, and you can see dorsal osteophyte, narrow joint space, and first metatarsal head square.
Yes.
In the stage 3, you can notice severe osteoarthritis with the cartilaginous degeneration and increasing inflammation. In the stage 4, we have a disappearance and the joint space and the pathological remodeling, leading to ankylosis. Symptomatology. We can evaluate the joint movement degree using particular device. In the stage 1, we can treat the hallux rigidus in a conservative way. The rigidity of the first metatarsal phalange determines a varus effect on the forefoot with overload on the lesser metatarsal. We can see an oblique fold form on the shoes in correspondence of the first MPJ, demonstrating in external walking. In this slide, we can see the overload of the external border on the foot in hallux rigidus. Footwear is important to relieve pain while walking. The rocker bar helps to compensate the first MPJ rigidity and provide relief for the painful metatarsalgia. The aim is to reduce the dorsiflexion and the metatarsal phalanges level. The MBT shoe, for example, is a valid commercial choice. If a woman is affected from hallux limitus, she should forget flat shoes, obviously, because they will have pain in walking. I remember that in opportune modification under the first ray, it improved the first MPJ movement, can help to limit excessive pronation force and decrease pain. It doesn't work in degree 3 for hallux rigidus. Indeed, the soft pad applied under the diaphysis in the hallux proximal phalanx induces a system of force that dorsiflex the first phalanx when the head of the first metatarsal lowers in the third phase of the step. In advanced stage 2 and 3 and 4, surgery is the best choice. However, conservative treatment is even possible. What are we going to do? This is what I use as surgical algorithm treatment for hallux rigidus. I use an oblique osteotomy in the treatment of the hallux limitus stage 1, 2, and 2. This osteotomy was presented for the first time in Basel in 1996 and published on the Foot Surgery Journal in 2000. This type of oblique osteotomy gives the possibility of spatial transfer of the metatarsal head with 4 degrees of freedom: plantar, lateral displacement, shortening, and rotation of the head. Here we can see my osteotomy with 4 degrees of freedom. Plantar, you can see, shortening, lateral displacement, and rotation of the head. Surgical procedures. First, I do a dorsal medial incision when we perform a capsulotomy and shaving on the first MPJ. Next, I remove osteophytes.
Okay.
Shaving the first metatarsal joint, in this case, you can see another slide when you can see the osteophytes removed. In this slide, you can see elevation of the head, articular arthritis, and remember, the elevation of the metatarsal head is always present. A triplanar osteotomy is performed with the 4 degrees of special displacement, plantar, lateral, shortening, and rotation of the head, as we said before. After osteotomy, I can check the range of motion of the joint. In this case, it has increased. Now, the osteotomy is fixed with 2 cannulated screws. And in this slide, you can see the lowering of the metatarsal head after an oblique osteotomy. This is a pre-op and the post-op after an oblique osteotomy. Toward an immediate post-operative X-ray control, you can notice an increase in the joint space. And it's very interesting. This slide represents my first oblique metatarsal osteotomy performed in 15 February in 1995 to my cousin. The X-ray show a good preservation of the first metatarsal phalangeal articular space. It has been maintained over time, clinical control and X-ray 25 years later. Because this is another case, 9 years post-op check. Other indication, we can use this osteotomy for other indications. In this case, the oblique osteotomy can also be used when there is a severe hallux valgus. Also, when we have a long metatarsal, as in this other case, this osteotomy is the better choice because you have more chance to short the first metatarsal phalanx and successfully. This is a post-op control, good metatarsal alignment. In order to evaluate the entity of the displacement, we use a particular device created by self called OGR. They allow us to know the entity of lowering of the metatarsal head in relation with the cutting angle and the displacement expressed in millimeters. This is OGR seen in the various angles. Let's have an example. If I perform an osteotomy of the 20 degrees of lowering and I need a movement of the metatarsal head of the 4 millimeters, my head will go down, lowering of the 1.36 millimeter. With this simple card, we can mathematize an osteotomy. These concepts are described in my book in English. OGR application. Anterior view on osteotomy at 20 degrees of lowering. It is important that because you can evaluate the degree of displacement and the lowering to improve the rear forefoot rapport, as in this case. Still, we have other indication of oblique osteotomy. In some case of hallux rigidus grade 2 to 3, it is possible to use this osteotomy associated with an implant, in this case, a towel, with good functional result. Why an osteotomy and an implantation? When do we use it? I adopt the decompressive osteotomy and implantation in the hallux rigidus grade 3. I use it only when the metatarsal is long and elevated, without severe metatarsal sesamoid arthritis degeneration, hallux rigidus grade 2 to 3. This methodic was published in 2011 on foot and ankle. In this work, you can see the big toes range of motion increasing from 24.5 to 52.6 and the decrease in pain from 63.6 to 34.5. Surgical procedures. After performing an oblique osteotomy at the level of the first metatarsal head, I perform an economic osteotomy on base phalanx. I apply an perimetric measurement in order to place an implant, and apply a guide wire, and I mill the base phalanx. Next, I remove the hemicap trial, and at this point, I can finally apply the hemiprosthesis. Before sewing, I have to evaluate the new articulation and insert always growth factor. Now, I want to show you some clinical case pre and post-op as in this case. Pre and post-op after an implant and osteotomy. This is a valgus rigidus operated in 17 and control after 1 year. Other indication. Oblique osteotomy can also be used in the following cases. Here, you can see a severe iatrogenic varus that I treated with an osteotomy with opening at the metatarsal head. In this case, I translate the metatarsal head into the opening and the shortening, obtaining a good aesthetic and functional result. Here we have an iatrogenic result of the 54 years patient operated for hallux valgus. You can see the subluxation on the first and the second MPJ. You can see the pre and the post-op. Good metatarsal alignment can be seen. The same case, this is the post-op result. This is another case with severe subluxation in varus of the first ray, pre and post-surgery. That is very important, I think. Never use this osteotomy in severe case of metatarsal head degeneration and in hypometry of the first metatarsal head. We will have a certain failures. Never use it in this case. Always, this osteotomy may be associated with gastrocnemius recession, obviously when you have a short triceps fascia. Thank you for your attention.
All of the sponsors of this podcast are listed on the website at podofinquiry.com. You can get great offers on these fantastic products and services, and this will help generate revenue for the show, so that we can bring you the absolute best content. Thank you all for listening and supporting the show.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been. Paolo, that was excellent. I want to ask you a couple of questions. One is when you look at these patients, are you always making sure that they have adequate dorsiflexion available at the ankle joint? No equinus?
Quando l'ankle joint, cioè quando c'è? Cosa? Non ho capito. Can you repeat it slowly?
Yes. So if there's an equinus present, a limitation of ankle joint dorsiflexion, you always Yes, I use the gastrocranial recession and also the osteotomy. Yes. So, both. Because I've found that just with a gastroc recession, if they're really tight, I always get a little bit more motion at the first metatarsal phalangeal joint. But but you still need to do the osteotomy. But I think that if people are not paying attention to the equinus component, they will not get the ultimate result with your osteotomy or even with an implant in a stage 4 case.
If I have the gastrocnemius, the short gastrocnemius, and the first hallux, the result is not the same. This is the question.
Yes, that's the question. I think some people get in trouble and have complications because they don't address the tight triceps.
Say if I have the triceps short, I lengthen always my gastrocnemius always, because I will have more results.
Yes, and that's. Yeah, I agree, 100%.
I use the gastrocnemius often when I have the fasciitis and the gastrocnemius short.
Right.
With good result. At the time after surgery, there are the half time. Sono dimezzati, come si dice dimezzati? Sono half time.
Yes, I understand. Now, one of the other things that I think is very important when these people develop a lateral metatarsalgia, they may have pain sub-second, sub-third, and if you look at the first metatarsal is causing them to put all their weight laterally, That's a very important thing.
Yes, sometimes, yes. In the first lecture, I show that the first ray will be always little shorter than the second. But when I have metatarsalgia, or the second metatarsal too much long, I shortening the head always, both first and second, and sometimes the third.
Yes, and I think sometimes where people will get into trouble is there may be a stage 1 in the first metatarsal phalangeal joint that is causing them to supinate and to put more weight under the second, under the third, and
depends the angle. Because the osteotomy have 4 degrees the freedom. If you cut a lot angle and you translate, you have more più in basso, will go down much down.
Plantar flex it.
Supination.
Yes.
In this case.
Yes. Now,
to control, mathematize the osteotomy, I think.
So you were a mathematician before you became an orthopedic surgeon, correct?
Yes.
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 And I always tell people when I'm out talking that I believe you're the first surgeon that has ever applied true trigonometry to a metatarsal osteotomy. So congratulations to you for that. The other thing I remember you telling me was that for every 1 millimeter of proximal displacement of the osteotomy, you would get about 7 degrees of dorsiflexion.
All right. Allora, this is the grade, the inclination, the head. That is how much in the left, how much I can to translate. If I 10 degrees the lowering, and I translate the 4 millimeters, I will have 0.7 the shortening the head. If I put the 30 degrees the inclination, and I have 8 millimeters the translate, I will have 4 millimeters to put down my head.
Okay.
This is very important. But the important for me is migliorare, come si dice? Get better the rapport rear forefoot. The rapport rear foot deve essere must be the 90 degrees.
Okay.
This is very important. When you do translate, you need the improve the rapport rear foot for the foot, because if you have the first elevated, the first,
yes,
in non-weight bearing, when in a weight bearing, the first go down and you have the pronation. Of if my head is a lot put down, you have the supination. It's important, the rapport rear foot for the foot.
So yes, because if your forefoot is not ideally aligned with your rear foot, it will change everything that you're doing at the first metatarsal with this osteotomy.
Certo, this is in a frontal plane. If you have the second, the third, too much long, you have to shortening. It's a biomechanics problem.
So what about the? I understand what you're talking about from the translation of the head, making it more plantar, which we know is very important with this osteotomy. But what about the degrees of dorsiflexion for every 1 millimeter? Do you follow what I'm saying? If I shorten it 1 millimeter, how much dorsiflexion do I get versus shorten it 2 millimeters, etc.?
Se faccio 1 millimetro, quanto dorsiflexion c'ho?
1 millimetro in down?
Proximal.
Depends del coso, di come dire, della flexibility della skin.
Okay.
It's impossible to answer. It's impossible.
Okay. I understand. Is there anything else that people really need to think about before doing this osteotomy?
C'è qualcosa che devono pensare le persone prima di fare questa osteotomia?
Check a good check in X-ray and good clinical before. Studiare meglio il paziente.
Give a right analysis of the patient.
Yes, good analysis the patient. Yeah. Study the good, studiare the patient very well.
And how do you manage these people post-operatively? Do you let them walk right away?
Normally walk immediately with the surgical shoes.
Immediately.
Yes. No
because
problem.
It's a very stable osteotomy.
Yes, you fix it with the 2 screws.
Yes. And the way the cut is oriented to the weight-bearing surface makes it stable.
No move.
Yeah. Very,
You
very.
can translate until 7 millimeters. You can, if you can.
Okay.
It's like a base wage, like not base wage, but you can translate it very well and very hot.
Right. Well, I have to tell you, I have been using your technique since the mid-1990s when you were kind enough to host me in Rome, and it is a wonderful procedure. It provides for so much ability to correct different deformities in different planes, because as you point out, you can plantar flex, you can translate the head medial or lateral, you can rotate it. Yes. It's a very versatile osteotomy, and I think it has a lot of application. And again, it's very stable, so you don't have to keep people non-weight bearing for very long or at all.
Very happy. Thank you.
Very happy. So tell me what else is new in foot and ankle surgery in Rome or in Europe. I haven't been over there for a while.
Cosa c'è di nuovo?
The new the hip implant, the spacer for rigidus grade 3.
Okay.
This moment, I study the new implants because the problems now is not the hallux rigidus 1, 2, because my osteotomy is very okay. The hallux rigidus grade 3 is very important. We begin to utilize the new spacer in silicone, and in the proximal when I will see you again, I will show you the new technique.
I'm looking forward to seeing that.
Very nice.
Yes.
It's okay for the sportive, but for not the young people, for the patient that don't go a lot of sport, very, very nice, because give the good movement and si usa resiste nel tempo, dice?
It's good in time.
In the time is okay. The time is okay.
Very good. Very good. Well, Paolo, I want to thank you so much for coming on the show and showing this osteotomy to the audience. And I'm very proud just to know you and have been able to learn from you. And I look forward to getting back to Rome in the future and spending some more time with you, because I've always had.
I wait you. You're welcome.
Yeah.
I wait you in Rome.
I look forward to it, and I really appreciate you taking the time for this. So thank you very much. And can you tell people how to find you if they have any questions?
Puoi dire alle persone che sta registrando dove ti possono trovare per
yes.
domande?
Allora, if I send you my email. Okay.
Yes.
Email,
and I will.
You have my email.
I have your email. I will put it in.
I can answer in English. I don't speak in English, but I understand.
Yeah. Well, I think you speak English pretty well, but I appreciate you doing what you did today and taking the time not only to be on the show, but the presentation as well. Yeah. And this will be something that people can watch the video, and I'll put those links in the show notes so people can see that. So anyhow, thank you very much. And I hope you have a great weekend, and we will talk very soon. Okay.
And you?
You too.
You too.
Thank you.
Thank you.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find this a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show and used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.